middle. And I'm just going to take control of the slides. Hopefully I have control. There we are. Okay, excellent. So by way of housekeeping, if I could ask people to keep their microphones on mute during the presentation. There is an opportunity for questions scattered through the course of the program. And if you have questions you want to ask, if you type them into the chat function, then we'll cover those at the end of each section. This meeting is being recorded, and if you want to remain anonymous, you can certainly do so by clicking on your name, right-click on your name, selecting rename, and put in whatever you like. But we are going to record this, and so we can put it on the website for the study afterwards. There will be some polls during the course of this evening, and we'll introduce them. We're going to make you guys do some work too and give us some feedback. We want your opinions, and so you don't have to answer the questions, and if you do, it's anonymous, so you won't be identified by your answers, but it'll be useful for us to use that information to guide where we go with our future work. So we're going to have a little trial run now. Is there a poll to run, Ricardo? So here's the first poll, just to sort of get us warmed up and see how it works. So if you could describe yourself on the poll, either a patient, a friend or relative of a patient, a clinical researcher, or another interested party, then that will be really useful for us to gauge the audience. Thank you. So we'll just give that a couple of minutes to run. Okay, good. Thank you for that. So I can see that the audience is predominantly prostate cancer patients, which is great because it's you guys whose opinion we want. In particular, we've got some researchers and one other interested party. So you're all very welcome. I'll stop sharing that now. There we go. And see if I've still got control of the slides. Yeah. So this is the program for this evening. I'm just going to introduce the trial and give you an update on how we've been going since our last PPI meeting through the pandemic. And there'll be a few minutes for questions and answers at the end of that. Then we're going to hear from Tariq Al-Hamouri, who's a fellow on the NeuroSAFE proof study. He's going to talk about an important concept of penile prehabilitation. We'll explain more about that, and we also want your feedback on the topic. So we'll be very interested to hear the results of the poll. We'll then take a little break, and we're very honoured. We've one of the patients for the study is a very talented musician, and he's prepared some recordings of some beautiful classical guitar for us while we take a little breather between 5:30 and 35 minutes past 5. We'll then hear from Ricardo Almeida, who is a fellow for the study, and will talk you through e-consent and e-proms, these tools that we've developed to help keep us going through the pandemic. Again, Q&A at the end of that section. And then we'll hear from Dr. Ayman Haider, who's the pathologist for the study, and she's going to talk to us about an important new technological advance called confocal laser microscopy, and what we're planning to do with that in relation to the NeuroSAFE proof study. We'll then have some questions, and we'll open up for more general questions just before we close off at 6 o'clock. So that's the program. I've lost control. Oh, there we are. So here you can see some pictures over the course of the study. The way we conduct these meetings has changed. Our first meeting in September 2018 was conducted in person, and you can see Owen Deneen, one of our former fellows, stood in front of the projection with a room full of patients. One of the good things perhaps that came through the pandemic was our use of remote meetings, and so we're now able to conduct these meetings remotely. It means we don't have to drag you halfway across the country to hear from you, and we can get more of you involved. So I think this is a positive development. Our last meeting was just over 2 years ago, so quite a lot has changed. I've been promoted and very honoured to have been promoted to professor, largely reflecting the work that the team has done on the NeuroSAFE proof project. So it's a team effort and a team honour. Owen Deneen is unable to join us tonight. Some of you will remember Owen, having met him in the clinic. He's busy doing surgery as part of his training, so I'll be carrying out his part of the presentation tonight. Next, we have Ricardo Almeida, who is a consultant neurologist from Mexico, who's joined us as a fellow and has been with us for about 1.5 years now and is doing fantastic work. So you'll hear from him. Eamon Haydar is our consultant histopathologist who has been on the study since the outset and has helped guide it and set up the pathology support that we need to get the information that tells us whether we can spare nerves or not. And she's also leading on the confocal laser microscopy work. Next, we have Tariq Al-Hamouri. You'll hear from him tonight as well. He's also a clinical fellow with me at University College Hospital. And at the bottom, you can see that we sometimes relax and we're all out to dinner as a team to celebrate the good work that's going on. So, questions. Now's an opportunity. If there are questions you want to type into the chat, then you should feel free. You can do this at any point during the course of the presentation, and we'll come to them at intervals. Are there any questions that have been posted so far? No, nothing yet. Okay, so no burning questions. I'm not surprised. There hasn't been really anything to that's contentious. So I'll tell you now about the progress of the study. At the outset, we designed the study to recruit 404 men. We've made fantastic progress. We have now recruited 369 men. So we're approaching our target for completion. And our first patient was recruited back in January 2019. We plan to finish recruiting at the end of November. We're now open at 5 NHS hospitals across England and Scotland. So we started at University College Hospital and very quickly got Bristol involved and Southmead Hospital. We then opened in Sheffield and subsequently in Glasgow. And most recently, we've opened at Nottingham. And this is our recruitment curve. So you can see the time course of the study. The red line is our objective. So when we design a study, we predict how many patients we'll need to recruit per month in order to reach our goal. And you can see that at first we made tremendous progress and then 2020 hit us with the pandemic, and you can see quite a profound change in the trajectory with a forced stop on the study on 2 occasions. So despite that, and credit to the NeuroSAFE Proof team and the 5 centres, we're now back up to speed again, and the trajectory is good. And I think we're in line to reach our target of 404 by the end of November. Okay, another opportunity for questions. Anything come through yet? No, no questions? There are questions.
Yes, one of our questions is that everyone here is in the study, yes, but not everyone has received NeuroSAFE. So that's one of the questions from our participants. And yeah, so the study has two arms and we have mixed group of participants. So we won't know the results of the study until we finish. So we cannot say who is who.
Quite right. Thanks, Ricardo. So yeah, it's a randomized study. Men who take part, 50% of them would have had NeuroSAFE. 50% will have had the best operation we can do without NeuroSAFE. It's a pragmatic design so that we can find out, does the NeuroSAFE procedure add anything in terms of potency, but also urinary continence for our men? Any other questions come in, Ricardo? I can see a question here. What next after the 404? Will the trial be extended? So really good question. When we've completed recruitment, and it will be around 404, we may over recruit or under recruit slightly, but we'll aim to hit 404 on the head. And we will then pause recruitment and the study will then go into a follow-up phase. The main outcome is potency at 1 year after surgery. So we'll continue following up our participants for a year, and then we'll close the study and clean and analyze the data before we come up with what we hope will be a definitive answer as to whether this intervention is something that the NHS should be providing. Why 404, someone's asked. So this is based on quite a complex calculation wherein we've estimated the size of the difference we expect to see between the two groups, and we calculate the number of patients that are required with that estimated difference to give a conclusive, statistically significant, i.e. not likely to have occurred by chance, result that we can then be pretty confident is reflective of reality. I think that's it for the questions for now. So without further ado, I'm going to hand over to Tariq Al-Hamouri. Tariq, are you ready?
Yes. Hi. Actually, there was one question if you want to answer it quickly.
Which one? Can you read it out for me?
Is the surgical procedure the same for each arm of the study apart from the intraoperative pathology involvement?
Yes. So in the NeuroSAFE arm, we stop the operation for about 45 minutes while we analyze the surface of the prostate, and we use the results of the analysis to tell us if we have caused a positive margin or not. If we have, we then resect the nerve on that side, assuming that it's involved. If the patient has a standard operation, I do what I normally do, the best operation I can with the intention of getting rid of the cancer and sparing as much nerve as possible, but using the MRI scan that everyone's had pre-operatively, pre-biopsy, to guide whether we can spare nerves or not. There was another question just came in. Presumably, assuming a positive outcome, it will become the new normal. Will all centres then be re-equipped to perform via the NeuroSAFE protocol? Again, a really important question. So that's why it's important that we get answers that we are pretty confident reflect reality. That high level of evidence is then quite persuasive, and we would approach the people who make policy for the NHS. They're called NICE, and we would talk to them about our results, and if they're compelled, if they feel it's a cost-effective intervention, then it's something that we hope the NHS would roll out. One of the other good things about this study is that in setting up and carrying it out, we now have 5 UK centres who are equipped and able to perform NeuroSAFE. So in a sense, we have a network of centres who can perform this intervention. The impetus will be on other centres to equip themselves if this is deemed to be cost effective for the NHS. Thank you for the questions. Tarek?
Thank you very much. Good evening, everyone. I'm Tarek Al-Hamouri. I believe I have met most of you for your UCLH follow-up appointments. Before I begin talking about this project, allow me to start with some background information. As you may know, we have seen remarkable achievements in prostate cancer diagnostics over the course of the last few years. This in turn have shown increasing number of younger patients and sexually active patients requiring surgery. Despite doing our best in getting maximum nerve sparing with the robot, erectile dysfunction remains a challenging consequence of the surgery. Erectile dysfunction after surgery results from damage to the nerves, as well as to the blood vessels and the smooth muscle fibers. Some more knowledge here. Men with normal erectile function have 3 to 6 erections per night during the rapid eye movement sleep phase, which exercises the tissues and keeps them healthy. Following damage sustained by the surgery, it appears that the longer a man goes without erections, the more tissue damage occurs and the more difficult erections are to restore. Current rehabilitation methods include the vacuum erection device, erection enhancing tablets, such as Viagra, sildenafil, tadalafil, penile injections, or what we call intracavernosal injections, ICI, or intraurethral medications, or a combination of the above. Next slide. Yeah, so here you can see multiple studies have proven the efficacy of early rehabilitation as means of improving blood flow and mimic the daily physiological erections that we mentioned earlier to facilitate early sexual intercourse, early patient partner satisfaction, maintenance of the penile size, and return of natural erections. Next, please. So, as part of our continuous efforts to battle the post-surgery erectile dysfunction, we are proposing this new concept of pre-habilitation as a new approach to achieve this common goal. We aim to have a pre-surgery meeting with our patients. We offer our patients the vacuum erection device, and we make sure that they get a teaching session on how to use it. We would also prescribe the tablets to be used as soon as the patient is ready. We can also teach patients and talk about the injections and the intraurethral medications should they be required later on. We believe that this way our patients would feel ready and have the encouragement that they can manage this expected side effect after surgery. Now is the time for questions. We will start with our first poll. We would very much like to know your answers to the following question. So do you think it would be better for the patient to have a vacuum device before the operation? What the current standard is, it's after the operation. And second question, do you think it would be better for patients who were taught to use the injections before the operation, or the current standard is after the operation? Give that a minute for everyone to participate. Yeah. So we have 85% participation. Now, this is the results. Very interesting. 70% would prefer to have the device before the surgery, and 50-50, almost 50-50 on if to be taught to use the injections before the operation. Thank you very much. Now we're gonna go to a second question. This question might be maybe conceptual, a bit complex, so I will precede it with a little explanation. So when we are planning a study or a research study, we need to know what the patient's preferences are. So if we're talking about, let's say, timing-wise, should we be more concerned about helping patients return to sexual activity with the help of tablets alone at some point, which could be later on during their recovery? Or the second option is aim to achieve earlier or a satisfactory intercourse as early as possible with the help of other adjuncts, such as tablets, injections, vacuum device, or a combination of all or two of them. I will bring it up as a poll now. I would very much appreciate your participation. Thank you. I'll give that a minute. Excellent. Fantastic. Thank you very much. So it's more in favor for earlier return to sexual activity, even if it was with the help of other erectile enhancing aids. Thank you very much, everyone, for listening. Thank you for participating in the poll. I will leave it to you, Greg or Ricardo.
Thanks, Tarek. That's very helpful. We've just got one question that came in that I didn't see. It must have been at the end of my introduction. So it says here, clearly there will be post-operative cost savings to the NHS, presumably they mean with NeuroSAFE. Will there be a pharmacoeconomic follow-up that will enable you to justify any further scale-up costs? So those of you who've participated, sorry, camera on, those of you who've participated in the study will know that the questionnaires include a health economic questionnaire, which many people have completed for us, which give us an idea of what the cost impact of the study is for the patients and for the NHS. And so, yeah, this is a really important means by which we have to calculate, is this a cost-effective means by which to improve sexual function for men? Okay, any questions for Tarek based on his presentation? Feel free. Well, don't seem to be any new questions coming in, which implies that we probably all need a short break just for a leg stretch, comfort break. And so at this point, we're honoured to have music by Javier Fioramonti, and I hope you enjoy it. We'll take a 5-minute break and resume at just before 25 to 6. Okay, does that mean we're ready to restart, Ricardo?
Yes. Sorry.
Great. Okay, thank you. There's a couple of questions coming over the interlude. I hope you enjoyed the music. Question: how long should we be waiting for help with erections? At the moment, there's not really a standard across the NHS. I would advise you to see your clinician and engage and request that you see an andrologist relatively early, so that you can explore the medications that Tarek told you about, the vacuum pump device. To my mind, the sooner the better, but there are obviously limitations. But the feedback that you've given will help shape what we do as a study, and there seems to be a desire to start things early, and that's important. The next question on there, does the data so far give you confidence that NICE will support a judgment of cost effectiveness? So cost effectiveness is difficult, and we're waiting for the definitive data and the definitive analysis. What we did see in the feasibility study was that using NeuroSAFE, we were able to spare more nerves. Whether that translates to an improvement in erectile recovery is one question that hasn't really been answered in any of the studies, but we'll be able to answer that when our data is mature. In terms of the cost effectiveness, clearly we can only answer that when we have the data regarding what the cost implications are for the patient and the NHS. And so we'll wait and see what that shows. When we've got the definitive data, we'll share it widely. Are there parallel trials internationally which you are linked with, is the next question. So we learned the procedure from a team in Germany at the Martini Clinic, who do lots of this surgery, and they publish their results regularly. They get very good results, and they do NeuroSAFE for everyone. Clearly, finances are a bit looser in Germany. During the early stage of our study, we spoke with a place called the Erasmus Center, which is in Rotterdam in the Netherlands. And we were contemplating forming this study on an international basis. But the team in Rotterdam felt that they didn't want to have a randomized study. And they've now published their data, and in keeping with that which we saw in our feasibility study, they report that using NeuroSAFE, their positive margin rate is not affected detrimentally. So their cancer control is as good, and they seem to spare more nerves. They published that data, and the level of evidence that provides is not definitive. It's suggestive and it's persuasive, but it's not definitive. We need randomized data with patient-reported outcome measures, which is why all of our participants fill in the questionnaires very carefully, because those are the patient-reported outcome measures. There's another question here. I completed the questionnaire after 1 year and had interviews during that year. Will there be longer-term follow-up to ensure patients off the trial remain cancer-free? So with prostate cancer, your follow-up needs to be with regular PSA tests to check that the level remains nice and low. If it rises, it suggests that you may require extra treatment, usually hormones and radiotherapy. So that will be done outside of the study as a matter of course, anywhere within the NHS. So if anyone's had a radical prostatectomy, they should be having regular PSA checks. And that might be with the GP or in the hospital. But that's how we ensure that you remain cancer-free. In terms of follow-up on the study, we are just writing an amendment to our protocol. Obviously, everything we do is carefully regulated and has to be approved by an ethics committee, but we're putting in a request to administer a questionnaire regarding function, so erections and continence, at a later stage during the course of the follow-up period. So if we get that approval, then we'll be sending that questionnaire by EPOMS or paper if it's required to our patients. The next question that's come up, I have had a non-nerve sparing op. I am 100% and now use a combination of pump and injection, which is pain-free. Will there be a nerve transplant to regain a natural erection? That's a really good question, and it exemplifies 2 points. That we try and spare as much nerve as possible in the hope that that allows people to regain their natural erections. But even if that doesn't happen, it doesn't mean that you can't be sexually active. Thankfully, we have very good means. The injections, the tablet that the man puts down through the end of the penis, and the vacuum pump devices are highly effective. And so, you know, it's not the end of the story, even if nerve sparing hasn't been positive. The next question here is really very interesting. The questionnaires we had to fill in seemed quite heteronormative and did not seem to address men who have sex with men in their design. In your sampling, did you seek to have a cross-section of participants based around sexuality and ethnicity? So again, that's a really good question, and one that it's become apparent it is more important, and I agree, the questionnaires that are used are not just heteronormative, but they focus only on penetrative sexual intercourse, which is not the be-all and end-all for some men. So I think there are flaws in the questionnaires that we use. The questionnaires are picked because we know what they mean, in that they've been validated and are recognized as a standard, well-known means to evaluate erectile dysfunction. But I acknowledge that there are limitations, as I've described. In our sampling, we haven't actively sought to have a cross-section of participants around sexuality and ethnicity, but I'm very pleased that we have that. And it's been a learning process for me to see the feedback that comes back through the questionnaires. And again, this question exemplifies that. So yeah, thank you very much for that question. Really important. There's loads of questions coming in now, so I will get through as many as I can before we move on. What percentage of patients get back to normal after a year, and how many without any help other than vacuum pump? Sorry. What percentage of patients get back to normal after a year? So the data that's published seem to suggest that if we do a full nerve spare in someone who's fully potent, they've got about a 70% chance of getting erections that they can use for penetrative intercourse 2 years after surgery. The level's slightly lower at 1 year. How many without any help other than vacuum pump? Well, the thing about the vacuum pump is it doesn't depend on nerves. And so you using a vacuum pump, every man, provided they're taught how to use it properly, should be able to get a usable erection. It doesn't depend on the nerves at all. Would it be possible to have full erection without the aid of tablets at some point in the future? Some of the men that I've treated and done a full nerve spare on have been able to get erections without the use of tablets, but it's pretty unusual. So the statistic I quote, 70% at 2 years, is using tablets like Viagra. Usually nowadays, tadalafil 5 milligrams once daily, with a slightly higher dose for some men when they wish to be sexually active. For how long should PSA testing carry on post-surgery? This is based on, so depending on how bad the cancer was, the duration of PSA testing is sort of personalized. So if one's had a very aggressive cancer, one needs to be diligent for longer. But I would recommend an annual PSA test for at least 5 years after surgery. And if you've had a high grade or a cancer that's working its way through the capsule of the prostate, or your PSA was very high at the outset, then that should continue for longer. And you would discuss that with your urologist. The important thing is not to forget about it altogether. It's got to be something that's in the back of your mind. And if you've had a radical prostatectomy, you should have either no PSA or very low levels of PSA. And if your PSA is rising, you need help. And that would be brought on by talking to your urologist about it, and they'd probably refer you to an oncologist. Okay, a couple more questions. If there are 2 patients, both resulted in 100% nerve sparing in left and right sides, however, one received NeuroSAFE and the other didn't, will the person who received NeuroSAFE have a higher probability of erectile function afterwards? The answer to that is no. So it's only dependent on the amount of nerve we spare. Interestingly, the nerve sparing seems to promote continence as well. That's something that's seen in other studies as well as our data from the feasibility study. But the amount of nerve dictates how likely the erections are to return, rather than how that nerve sparing was achieved. I think there's one last question. I had no issues with incontinence, and erections were fine straight after. The whole process has caused me very little inconvenience at all. Was I just lucky? You could say you were lucky. I would like to think that it was because you had a good operation. We work hard to improve our technique, to spare the structures around the prostate. And certainly we see that the chance of someone having a plain sailing recovery, as you've had, is more likely if we can spare the structures around the prostate, including the nerves. Last one before we move on. It seems the andrology team patient support should be important to rehabilitation. What does the NeuroSAFE team do to attempt to ensure that the andrology team deliver the patient support it should? So through this study, we are gathering a lot of data about return of erections. And in that, so the degree of andrology support, it does seem to be important, but it varies across the country. And we will gather information about how important it is to have andrology interaction and at what point. That's another thing that will come out of the study. My feeling is, and the feedback that you've provided, is that andrology support should start early. And there are various approaches that we've discussed that they should be looking at providing. Okay, that's all for the questions. So we should move on. Thank you for those, really stimulating. The next section, can we have the next slide? Is on e-consent and PROMs. So at this point, I'll hand it over to Ricardo Almeida.
Hello. First of all, I want to thank everyone for coming, for staying with us. We owe everything to you, to the patients. And without your cooperation in these hard times, I think we wouldn't have been able to get to the point where we are. And we all know that COVID has been tough on the world in general, and that also for the world of research. And more than 1,000 clinical trials were canceled due to the pandemic. So when the pandemic hit and the lockdown started, we didn't want to suffer the same fate and throw away all the effort and all the commitment that we had from patients. So in response to this, during the first lockdown, the marvelous team that we had developed some solutions to be able to continue the trial whilst being safe and while avoiding as much as possible the contact and getting you to travel as least as we could. So we developed two solutions, basically. The first one was the e-consent process, which I'm sure a few of you have tried when enrolling in the trial. And the other one was the collection of remote questionnaires using electronic methods. So I want to present to you the e-consent process here. Once we send you a link to consent to be joining the trial, you receive this image where you can do the same thing you would do in a paper-based format. And it's all agreeing with all the regulations. It's safe. It's stored behind encryption and behind a secure email, which is the NHS one. So we believe this tool has been very valuable to continue the trial. And this is what happens behind the screen, our end. So when we send you the link and you accept, we process that request in a way that can allow us to get and record everything that happens. So if a patient agrees to participate, we can record that. If a patient then says no to participating, we can also document the reason he didn't agree to. And it's all stored securely behind a data safe haven in the university and in the NHS. And a hard copy of the consent form is printed and stored securely, and a copy is sent to you via the email. So since the implementation, more than 100 patients have been enrolled using this new tool. We have required limited troubleshooting, and it even allows us to consent for optional biobanking, which is something very valuable that has helped us design new trials in 68 patients. So we believe that it has several advantages compared to the paper-based form that it's used mainly in other trials, and that we believe this is the future because it avoids physical attendance, it requires less travel, it reduces the carbon footprint and need for printing things, and it's even more secure because everything's stored, everything is traceable, and we can even if there's a mistake in the filling out the consent form, we can correct it. So we believe it's a critical tool that has allowed us to continue the trial. We have even published this because we want other trials to be able to do this if they want, and to help them set up. If you scan this using your phone, you might be able to look at the paper we published based on this new tool. And the other thing is the electronic questionnaires, which also have been very helpful, and we thank you for your cooperation in filling them out. We want to know, please type something in the chat whether you like them or not. I think they're useful. It's a convenient way to send questionnaires, and it saves money and trees, because every set of questionnaires requires around 38 pages to be printed. So it's a lot of paper, but that we're saving using this tool. And all of the sites are using this new tool now. And we have had a high return rate of these questionnaires. So once again, I want to thank everyone for their participation. And we want to ask you one quick question. Let me share the poll. So we want to ask you, if you were to participate in another study, which of the following methods of consent would you prefer? Okay, that was quick. Thank you so much. We're almost, everyone has participated. And let me share the results. So yeah, 100%. So thank you for that. So we will move on to show you the next projects that we have on mind following the NeuroSAFE study.
Thanks, Ricardo. So just to say that the work to set up e-consent and e-proms was largely by one of our former trial team members, Jack Grierson, who's now moved on. But it really is a game changer, and we published the paper to share what we consider to be best practice. And it looks like you agree that electronic consent is a better way to proceed. So thank you. It's very rare to get such a unanimous result. Let me introduce Eamon Hayder, who is our pathologist for the study. Eamon's been involved from the outset and helped design the study. She also has analysed most of the samples at UCL and taught a number of pathologists across the UK to be able to perform and interpret the data from the NeuroSAFE procedure. So without further ado, thanks, Eamon. The floor is yours.
Thank you. Thank you, Greg, for that introduction. Can I have the next slide, please? I'm at the moment currently in Leeds, attending the British Association of Uropathologists conference on prostate cancer. And I've had the chance to catch up with a lot of our participating site pathologists. So I'm just thinking of 5 years back when it was a bit difficult, seemed difficult to convince pathologists and laboratory staff to donate 40 to 45 minutes of their time during a NeuroSAFE procedure. And meeting all of these people today, I'm glad to say that we have, in 5 years, overcome that challenge and incorporated all our skills and practices to establish the technique and train pathologists and laboratory staff across all the different sites in hope to bring about change in patient management. This first slide is essentially showing you what we do on a routine basis. It is now standardized and protocolized, the whole technique. The prostate comes to us inked with the margin that is adjacent to the nerve bundles. And this margin is inked by Greg in theaters. What we tend to do is take this whole wedge of the ink surface out, and then we cut it into finer sections, which you can see on that little disc over there. These sections are then cut by a technician, and then we stain them with very pretty pink and blue stains to generate a slide, which you see at the bottom of this this whole slide. These two slides, one of them has cancer in it and the other doesn't have cancer in it. And at the edge of both these slides, you can see a nice inked margin. During the course of this trial, so many cases that we've done, there have been many happy days when we have found this margin free of tumor, and Greg has managed to leave the nerve behind. Can I have the next slide, please? Now, as you realize, when I tell you about the whole procedure, there is dependence upon the technician who is cutting the slides. There is dependence upon all the machines that are used in the frozen section analysis, there is a time dependence and operator dependence, which has its problems and limitations. During the course of this trial, we've been trying to improve all the pathways from the specimen coming into pathology and the specimen making its transit through pathology till we see and analyze those slides for frozen section and thereafter. And in improving and innovate these pathways, we've been trying to innovate new methods and have collaborated with industry colleagues to evaluate a confocal laser microscope. The essence behind this technique is that the whole posterior surface that you saw, ink that we take out and cut, that also involves times, is just dipped into a dye and then placed on this confocal microscope. And the screen that you see of this microscope generates an image which is similar to what we see in the slide of the frozen section slide. The whole advantage is this whole procedure of dipping it in ink, putting it on the microscope and generating the image takes just up to 3 minutes compared to the 40 to 45 minutes that happens for a frozen section analysis. So we can obviously see the time advantage as well as less technical dependence. But what we have to evaluate now is whether these images that we are seeing are as good as the frozen sections that we have been reporting on. And again, to evaluate whether it is as good, we need a carefully formed plan, just like we had with the NeuroSAFE trial. And with the experience of having run the trial team is in a process of building up a protocol for this plan to see if it is effective enough to change what we are all doing at different centers across the world and change practice eventually. We will need that plan forwards to, can I have the next slide, please? Can I have the next slide, please? And this previous slide, can we go back to the previous? Yeah, this slide just outlines our thoughts on how we would like to take NeuroSAFE to LaserSAFE using this confocal microscope and evaluate this for better management and better pathway in pathology and better results for the patient. And so my question to you now is, do you find the idea of LaserSAFE appealing for future patient care and management? And would you recommend participation in a planned LaserSAFE study to a relative and friend, just like you have participated in the NeuroSAFE study? Thank you. The other advantage I also want to mention with the LaserSAFE is that in the NeuroSAFE, we're just cutting a few sections and making slides out of them. Whereas with the LaserSAFE, you can see that we've dipped the whole surface of the prostate and the whole surface generates an image. So again, it would be very interesting to see how that translates into reporting and nerve sparing.
That's brilliant. Thank you very much, Eamon, for that. Your insights are fantastic, and it's brilliant to see another almost unanimous poll showing support for the proposed study. This is something that we are developing. It's a work in progress, but the aim would be to show not only that it's quicker, but we want to see that it's as good at telling us if there's cancer at the edge of the specimen as the frozen section technique. So this is work we're planning, and we'll keep you abreast through the NeuroSAFE Proof website. Thank you. So this next slide is really just to show you how busy we've been. We've published our protocol. So when we carry out a study like this, it's really important that we're very transparent on exactly what we've done. So this is available for anyone who cares to look at it, and it describes exactly what we do for the NeuroSAFE Proof study, the paper on the far left of your screen. To the right at the top, you can see the paper we published on e-consent. And again, this is publicly available and is being used to set up a similar process for other studies. And then at the bottom, you can see another paper that, that Owen led on, looking at how good the MRI scan is in telling us whether the tumor is likely to be involving the nerves or not. We've been very busy. We've been presenting the work at conferences, the British Association of Urological Surgeons, where the work was awarded a prize, the European Association of Urology, and also the joint meeting of the British and Irish Pathological Society. Is that what that one is, Eamon? It's
the British division of the International Pathological Society, along with the Pathological Society of Great Britain, and it's one of the most coveted national pathology conferences.
So the study is getting lots of airtime within the profession, which is good. So people are interested in it. I have thank yous to make. So firstly, thank you to our funders. Thank you to the Rose Trees Trust. Thank you to Orchid. Thank you also, and particularly to JP Moulton, who have provided the funding for the full definitive study, and also to the National Institute of Health Research, which is the research branch of the NHS, who funded the feasibility phase, the early phase of the study. I'd also like to thank our collaborators. So the team at UCLH, you've met almost all of us. Thank you to Lorenzo Dutto and his team in Glasgow, John Aining and his team in Bristol, Neil Oakley and his team in Sheffield, and Tom Walton and his team in Nottingham. Most importantly, thank you to you for your help in setting up the study, your feedback. Your feedback's really important, and it's changed what we do during the course of the study, as well as giving us ideas on where to go next with this. So this is not going to be a story that ends when we close the NeuroSAFE proof study. There's more work to do. If any of you wish to stay in touch, there is an email address here, which we would value your contact, and will endeavour to answer any questions that we haven't covered in this meeting. I hope you've all seen the NeuroSAFE proof website, and if you haven't, have a look. We also have a Twitter handle, which you'd be very welcome to follow. Just before we go, we have one last question. So will NeuroSAFE enable you to be able to identify that more, in brackets, all of the cancerous tissue has been removed? So that's a really important question. One thing that becomes apparent, the NeuroSAFE procedure only allows us to look at the area which is adjacent to the nerves. It's the most important area with regard to nerve sparing, but as I mentioned earlier, we know that the other structures around the prostate bring function, and so preserving them seems to make recovery from surgery better. So we're interested in the ability to examine larger areas of the prostate surface quickly, and we can also examine areas that until now hadn't been examined, with a view to guiding us as to whether further resection is required. So we're quite excited about NeuroSAFE. The first thing, though, is to show that it's as good at detecting cancer at the edge of the prostate as the NeuroSAFE procedure. And this is brand new stuff, but we're very, very honoured and privileged to have the equipment and the means to explore it. So I think that probably draws everything to a conclusion. How do we do for time? Oh, we're right on time as well. I'm very pleased. I usually waffle on for a bit. Thank you all for your contributions. We will put the video of this up onto the website in due course. I wish you all a pleasant evening.